Good morning, everyone. My name is Gordon Glazer, and it's my distinct pleasure as the chair of the Alaska Commission on Aging to welcome you to this Zoom conference about reopening facilities for older Alaskans. This is a constantly changing topic. Things change as we move along, but we will give you a snapshot in time of where the latest information is today from those of the decision makers and those people who have knowledge of it. I'm going to have a couple requests before I begin. If you could mute your microphone and mute your camera, that should be on the side or the bottom of your screen. Just have a little red light through it. Well, this will allow us to save some bandwidth and keep background noise from affecting the speakers. If you have a question, you'll see a little chat on the right-hand side or the bottom, depending on how it's set up. Please type in your questions. We'll take all the questions at the end and do our best to try to answer them. And with that, I'd like to, again, welcome you all coming. We have people, well over 170 people at this point. I'll give you a count at the very end. This is the important issue of the time. And we have the lady of the time. I have her own, she has her own little sticker, which I have. And that's Dr. Ann Zink. She's the Chief Medical Officer for the state of Alaska with a mission to promote the health and well-being of Alaska. I would also say she's the star. So my pleasure to welcome Dr. Zink. You're on.
Great. Thank you so much for the opportunity to be here and to be meeting with all of you. You all have a challenging task, and I just really appreciate the amazing community that takes place in Alaska, the way that we can support each other, those who are at higher risk, and how we are all connected together. This disease continues to remind me of how connected we all are, even if we don't necessarily see it, and the way that one person can be exposed and the way that that can expose to other people. We have been very fortunate in this state that we have not experienced as much COVID as many other states. We really continue to see large outbreaks, particularly in nursing homes and long-term care facilities around the United States. We have had an outbreak in the transitional care facility associated with Providence, and that's been a humbling experience to just see how incredibly contagious the disease is. And then also just learn about the patterns of workers and staff and patients and the ways that we can learn from each one of these experiences and continue to mitigate the disease. We continue to really be thinking about the health and well-being overall, and that includes the mental health, which includes being social and being connected to people and family and loved ones. So a lot of work happening on visitation, on congregate settings, and the ways that we can be mindful. I'm constantly reminded in this disease process about how if we can give a little, we can get a lot. And so by doing things like meeting outside, by washing our hands on a regular basis, wearing fabric face coverings or masks when we are around each other, the more we can do to mitigate this disease. It's easy to hang with each other and to be able to protect those who are elderly if we keep the overall disease burden down. When the disease burden gets high, it becomes very hard to protect any one group, and particularly those who are most vulnerable. So I think that the overall strength in Alaska has been the fact that we've been able to keep the overall disease burden low and continue to work hard to do that. There's four major things that we think about with kind of the acceleration of COVID, and one is specifically travel related, and so that's why we've put a lot of testing and effort into travel related screening to use our geography to our advantage to isolate and identify cases early to try to keep that burden down. Another is in that kind of pre-symptomatic or asymptomatic spread, people who don't know and maybe carrying the disease. And I think that's one of the other really challenging things about this disease is there's no clinical diagnosis that's very easy, and it really relies on a test, which are imperfect and can be hard to get. And people can be much more infective prior to having symptoms than many other diseases, including things like SARS, which is another coronavirus, or even influenza. And so I think that that has made it much more challenging to isolate the cases early and identify them, and why testing is an important part of it. Two other big things that can cause acceleration of the disease include congregate settings, and so where people are living in close communities together. And we think about that both in our rural communities and multi-generational housing to long-term care facilities and other places where people live in close contact. There's clearly a large spread within those family units and those close contacts, and so that's another accelerating force for this disease. And so when we're looking at how to mitigate COVID overall, we're looking at like all four of those factors, what ways we can keep that disease burden down, but also finding ways to be healthy and happy together. And so we really appreciate the partnership, seeing and learning from you all on the ways that people are able to provide both mental and physical and spiritual support for each other and staying connected, and looking forward to finding more ways of doing that moving forward. So I'm happy to answer questions at the end, and I'll hand it back over. Thank you.
Okay, thank you, Dr. Zink. Our next speaker is our old friend, John Lee. He's the Director of Senior and Disability Services. John serves also on the DHSS Emergency and Operations Center as the Long-Term Care and Vulnerable Center, and also on the Long-Term Care Vulnerable Alaska Task Force Chair. John is board certified in healthcare administration from the American College of Healthcare Administrators, and has over 36 years of experience in leading healthcare organizations. And I will also say, John is a particular friend for the Alaska Commission on Aging, and we appreciate your support, and we appreciate you being here today. It's yours, John.
Thank you, Gordon. Can you hear me okay? Perfect. Thank you. And all right, thank you. And it's my pleasure to be here, and it's a tough act to follow Dr. Zink. Of course, I can't think of anybody that's more competent and capable of helping to lead the state through this time of great challenge. But the congregate settings, as Dr. Zink talked about, this is why we're so cautious and moving forward and making sure that we got the right systems in place before we're able to open up. Because you think about it, you got the highest risk population by definition. Typically, those who come to the senior centers are 65 or older, and quite often they have other health conditions that make getting COVID not a good thing for them. And then you got the congregate settings, which are the highest risk setting of all. And so you got the highest risk population in the highest risk setting. Certainly, it's an area that we need to be concerned about. And if you look nationally, in some states, up to 60% or more of the deaths have come from the congregate settings. And as of last week, unfortunately, over 51,000 Americans have died from who contracted COVID in a congregate setting. So certainly nothing to be discounted. And as you're aware, Health Alert 7, which was issued back in March, shut down congregate settings across the state of Alaska, and that's still in effect. And I could tell you that that's something that's being discussed and monitored on a daily basis, and where we're at and when we could open that up. And when the time is right, we will do that. And part of making sure the time is right is make sure we have good guidelines. And Gordon asked me to come on and talk about a little bit about the guidelines and what it says. And then we'll have speakers after me that will go into more detail on some of the guidelines. But the guidelines that we've shared with the ACOA membership are labeled drafts, but once we open up the settings, we're able to take the draft term off and make them live, but they are still considered drafts since the settings are shut down. But if you look at the draft guidelines, it's a 10-page document. It's well researched. There's a lot of links in there, which makes it a very valuable tool to understanding what the senior centers need to do and before they're able to open up and offer services. And the guidelines, we had a host of people that helped us with that, to include ACOA members, AADD, Director of Behavioral Health, the folks, Healthcare Services, certainly SDS, EPI, CD, and we borrowed CDC guidelines and what other states have done to make it, I think, a great document. But the big part about the guidelines, it talks about screening, creating separation, and activities that will minimize or mitigate the risk of spread of disease. I'll go over a few of the things. Screening, the guidelines talk about how important it is to screen, where 100% of everyone who comes into the senior centers must be screened. The screening should include the visitors, volunteers, the employees that work there, and certainly the participant. And the screening needs to include a temperature check using a digital thermometer to check for temperatures, and the screening for certain questions on health conditions that may be indicative of being ill. And so that's really important that that's done. And you need to choose a location where it's effective to do that, where it can be controlled, and you could have adequate space and the queuing of folks coming in, so you don't have people congregating together as they come in getting screened. And so that's organized. Facilities need to have a plan in place for what do you do if somebody screens with signs or symptoms of COVID or has a temperature. So the facility needs to have a plan of how they're going to manage that. It's important to create physical distancing everywhere in the organization, so you're maintaining at least 6 feet of separation or greater for participants. Consider doing things outdoors. Outdoors with the wind blowing and other things creates it helps to mitigate the spread of COVID. You should consider cohorting folks into smaller groups where you have certain staff that are working with certain participants, and so that there's not folks going between groups which could potentially spread the disease. So consider cohorting. Taking a look at their health conditions. If you have an older person with multiple health conditions that make them high risk, consider creating additional barriers and separation for them, so they can maintain their health condition. For meals, consider staggering your eating time, so not everybody's eating together. And ensure that there's at least 6 feet of separation between folks. Even at the tables, have great distances between the table to make sure that 6 feet of separation is always maintained. And for anybody eating together, it should only be family members that are eating together in close proximity. And plated meals that are served to the individuals is certainly better than a buffet style. Buffet style is very difficult to maintain the separation and conditions that would mitigate the spread of COVID. So these are some of the ideas that are contained in the document that allow organizations to do this as safely as possible. Some of the equipment that facilities need to have in place is certainly cloth face coverings for everyone, that staff, volunteers, visitors, and participants. Those should be worn. The digital thermometers need to be on hand. Certainly adequate soap and hot water for washing your hands. If you're going to use a hand sanitizer, make sure that 60% or greater alcohol-based hand sanitizer. Now for PPE, typically in senior centers, there's a difference between PPE and the cloth face coverings. PPE is certainly appropriate for the facilities to have if somebody suddenly becomes symptomatic while they're at the facility. It'd be good to put on maybe a surgical mask and gloves and gown if there's bodily fluids or things that need to be cleaned up for somebody who suddenly becomes symptomatic. So facilities should have a limited supply of PPE to manage people who become symptomatic while they're in the facility. Other things that if you go around the state of Alaska now and you go into a lot of businesses, you'll see the plexiglass shields that are up in areas where people are in close proximity to create that separation. Those are certainly things that a facility should consider getting. And certainly I don't want to be on the conference and read a 10-page document to everybody, but the draft guidelines, again, are I think very well written and really incorporate a lot of best practice that we learned not only from CDC, but operators of senior centers across the state of Alaska who got a chance to participate in the draft guidelines. So I'll be certainly happy to stay on and participate, and turn it back over to you, Gordon.
Thank you, John. And that document is available. Can we make that document available on our website, or is there another source? Okay, we'll get that answer later to you, but we will make sure that document is available. Thank you, John, for an excellent presentation and working with the different programs to making it practical for us to reopen as soon as we can do so safely. Our next speakers are two. We've got Dr. Joe McLaughlin of the state, who is the state epidemiologist and state epidemiologist in chief of Alaska, section of epidemiology. The other one is Eric Morin, an epidemiologist working on behalf of Alaska's section of epidemiology. So they're going to give you some of the background and specific measures that will be helping us move forward. You're on.
Great. Thank you so much. Can you hear me okay?
Yes, loud and clear.
Excellent. Well, really appreciate the opportunity to chat with you all. And I have Dr. Eric Moring here as well, and I'm sure Eric will have some things to add. I just wanted to start out by really underscoring some of the information that I've already heard from John Lee as well as Ann Zink that I think are really, really important for us to take into consideration as we look to opening up facilities for visitation. You know, Dr. Zink mentioned the 4 factors associated with acceleration in the United States. You know, the first being travel-associated importation from areas of high concentration or high incidence of disease to areas of low incidence. Number 2 is congregate settings, you know, where you've got, you know, assisted living facilities, nursing homes, things like that, where people are living together. They're kind of with each other 24/7. The third is group settings. So anytime you have a group of people, it's a numbers game. So the more people you have, the more opportunities for transmission occur. And then the last is what we call cryptic transmission. And in congregate living settings, I kind of think that all 4 of these factors play into why we're seeing so many outbreaks in congregate living settings throughout the country and throughout the world. You have importation from oftentimes from outside the facility into the facility, either through workers or through people visiting. Number 2, you've got the congregate living setting. Number 3, you've got group gatherings that sometimes occur. And then number 4, cryptic transmission, which is silent transmission that typically occurs when people are completely asymptomatic, but they're infected, or they may be pre-symptomatic just before their symptoms arise. They don't know they're infected, but they're still shedding the virus. And then lastly, because this virus oftentimes presents in a very, very mild way, and unfortunately, that is when people are shedding the most virus, is right around the time of symptom onset. That cryptic transmission, to me, is what makes this virus so sneaky and so difficult to manage. And John Lee talked about appropriate screening, and I really am a big advocate for appropriate screening. He talked about fever, you know, temperature checks. And as everybody on the line knows, CDC had been for, you know, at least the first couple of months of the outbreak or of the epidemic, really underscoring looking for fever, cough, and shortness of breath. But now the list of COVID symptoms has really expanded greatly. And so for all facilities that are going to be doing daily screening, which you should do, I really encourage everybody to include the long list of signs and symptoms and check for all of those signs and symptoms every day. And that guidance is available. We've got testing guidance. If you just go to our homepage of our COVID-19 homepage for the Department of Health and Social Services, we've got testing guidance up on that, and we can send that out to this group if that would be helpful. But that provides a full list of signs and symptoms that people should be looking out for. I can't tell you how many times we are hearing that people who test positive come back to us and say, boy, you know, all I had was a mild sniffle. I didn't even have a cough. I didn't even have a fever. I just kind of felt a little bit run down or a little bit achy. we're hearing that time and time again. And so really set a very, very low threshold for testing, certainly in any staff or residents who have even the mildest of symptoms. And then obviously, as John talked about, you should have a routine testing protocol as well in place. But those are some of the high level things I wanted to really underscore. You know, in terms of, from an epidemiologic standpoint, what are the things that we look for in terms of measures that you can look at to determine when it is and isn't safe to open a facility to visitation? CMS has put out a list of 7 factors, such as the case status in the community, what's the epidemiology in the community looking like, what's the rate, what proportion of cases that are occurring in the community can be linked back to other people, they're epidemiologically linked, versus the number that you just don't have any linkage at all. If you don't have any linkage at all, it's more, that's more of a sign of widespread community transmission when you start to see a lot of those unlinked cases. And then what's the case status in the facility? Have there been cases in residents? Have there been cases in staff? Making sure that each facility has adequate staffing in case there is a need for quarantining staff or putting staff into isolation if an outbreak were to occur, access to adequate testing, universal source control, access to adequate personal protective equipment for staff, and local hospital capacity. Now, this guidance is specific to nursing homes, and I know that's a little bit different than this, what we're talking about, but I think all of these factors can be applied in various settings. So maybe I'll turn it over now to Dr. Mooring to see, Eric, if you have anything more to add. Eric, are you on? You might be on mute.
Hi there, good afternoon, good morning, I should say. This is Dr. Eric Mooring. I unmuted myself, I think. Hopefully you can hear me.
Yes.
So yeah, I wanted to run through a couple of things this morning. So as John Lee went through many of the key ideas with the guidelines, and then Dr. McLaughlin followed up with really the importance of screening, not just fever screening, but symptom screening more generally for people coming into facilities. So first, I just note that in the document that will be coming out from the state, we actually include the whole list of symptoms that CDC kind of recognizes as COVID-19 symptoms. So those will be in there. I want to try to share my screen briefly and maybe show a few things from the CDC website. So I think I'm sharing my screen now. Can people see that? Maybe now. Can you see that? Am I?
Yes.
Okay, great. Thank you. So this is the Maine Cdc.gov page, and you can go to learn more about COVID-19. So there are a couple of things on here I'll point out. First of all, there's symptoms. So there's a list of symptoms here you can take a look at. But then let me go back and look at actually a page here that they put up just in the past couple of days called Deciding to Go Out. And what I like about this page is that you can read through it, and it really provides some of the key background principles that we think about in epidemiology all the time when it comes to infectious disease transmission risk for not just COVID-19, but really any respiratory virus. And so we're looking at risk as related to how many people you interact with. So it's about the number of people, but it's also about whether they're new people you don't usually interact with. So this is gets to what John Lee was talking about with cohorting different groups. It's all else equal, the same group of people interacting repeatedly is less conducive to transmission, is safer than the same size of group, but the membership constantly changing. So that's one of the ideas on here. And then, of course, there's the idea about distance. Given how we primarily think this virus spreads through respiratory droplets in the air, those droplets fall out due to gravity with increasing distance. So more than 6 feet is safer than less than 6 feet, and so on. And then the final component is time, and how long are these interactions going on. And this is probably one of the reasons why residential congregate settings in particular, and I know that this call is focused on the non-residential ones, but residential congregate settings like nursing homes in the extreme, people are there pretty much all the time. The residents are there all the time. So that's yet another reason why they're at greater risk. For senior centers and other facilities where people spend maybe up to a few hours a day, it would be less risky than a nursing home, but that's still a very significant amount of time. So that's some good kind of background information to think about. What are really the key underlying principles for disease transmission? Then the next thing I want to go to on this website is to look at this tab, communities, schools, workplaces, and events. So there isn't, to my knowledge, specific guidelines from CDC about every sort of possible setting you can imagine, especially some of these non-residential congregate settings. But I would encourage people, in addition to looking at forthcoming guidance from the state, to also look at information here. So first of all, there's some good information about routine cleaning and disinfecting practices. Then there's also information for retirement communities and community and faith-based organizations generally. So while the retirement community's guidance is mostly focused on communities where people actually live there, and so they're residential settings, many of the key principles you'll see as you read more of these web pages are broadly applicable. And then for facilities that are more on the healthcare side, adult services that maybe have more of a skilled nursing component, if that's kind of the space you're in, then you're going to want to look at the healthcare professionals part of the website, and especially this section called infection control, which is a very, very long and elaborate website with lots of guidance for healthcare and healthcare-like settings. So switching back to our guidance in the state, the way I think about these things is you ideally want to prevent COVID-19 from getting into your facility at all. And the main way we do that, in addition to, as a whole society, trying to keep case counts down, because as Dr. Zink said, the best way to protect vulnerable populations and our elders is to have fewer cases in the community to begin with. But aside from that, in terms of what facilities specifically can do, this is where the screening comes in. But we know that no single measure is foolproof, and that especially because of this cryptic transmission that Dr. McLaughlin was speaking about, and the potential for transmission before people develop symptoms, we know that while symptom screening is a powerful tool, it is not a perfect tool. And so that's why these other measures about how to prevent the spread of COVID, if someone with COVID does come into your facility who's infectious, are really important. And that gets to the questions around distance, cohorting, time, and it's something that we've said before on this call, but I think it bears repeating. and that is, at least in the coming months in the summer, if there are ways that you can think about moving your activities outdoors, really encourage that. Outdoors, there's better ventilation, and then there's just more space for people to spread out. So no one measure is perfect or going to guarantee that there won't be or can't be transmission, but we believe that all of these measures brought together around screening, around distancing, fabric face coverings, washing hands, and cleaning and sanitizing high-touch surfaces. That'd be things like doorknobs and countertops and just places that you are touching with your hands frequently and then likely to touch your eyes and nose and mouth. That all of these measures together can make a difference. So I think I'm going to stop here, but we'll be looking forward to taking your questions and continuing to support you all in this work. This is a population that is really at high risk from COVID. There's a very strong association, not just with chronic medical conditions, but also with older age alone and severe outcomes from COVID-19. So it is something we're very concerned about, but we also know really the critical role your services play in supporting people and their whole kind of social and emotional well-being, and that's very important too. So I think I'll leave it at that, but thank you all.
And thank you, Dr. Joe McLaughlin and Dr. Eric Moore for giving us the epi background. Our next speaker is a friend of mine, Lisa Morley. She's a program manager for the Senior and Disability Services, and she's very important to anybody who gets any grants from the state in terms of making things work regardless of where you are. I also want to do a quick note. We're up to about 250 people. People from all the way from the Wrangell Senior Center to the Fairbanks Senior Center. So thank you all for joining. And with that, Lisa, it's yours.
Hello, good morning, everyone. Thank you, Gordon, and thanks, Emily, for organizing this teleconference. So I did just want to speak to the centers, senior centers out there, and kind of just give you some background now on ways in which the state can support your efforts. Keep in mind that Health Mandate 7 is still in effect. So the governor has not lifted that, and so the senior center congregate settings will still remain closed for the time being. But then once that health mandate is lifted, and you all are following the guidelines that we have put together for reopening, there may be some ways in which the state can help assist you in keeping your seniors safe and getting masks or organizing shifts in your meals, or expanding your pickup meals or home delivered meals. So I just wanted to let folks know. So currently, if you are a grantee receiving a nutrition, transportation, and support grant, you will be receiving additional funding in your fiscal year 2021 grant award that will be specifically for COVID activities. So considering that right now the congregate sites are not open, those funds can be spent to either expand your home delivered meals, create a pickup site, pay for PPE, or help put together some volunteers, organize volunteers to do check-ins for those homebound seniors. There's many ways that you can still deliver services without having a face-to-face congregate setting. And I know that we're all anxious to open up, but we also want to make sure that all of our participants are safe when we do open up. For those of you who aren't current grantees under the Nutrition, Transportation, and Support Services grant, I just wanted to let you know that we will be having a competitive process, that we will be offering up funding for senior centers and congregate settings to provide services to seniors 60 and over to apply for grants to help them keep people safe. So there's many options, there's many things that you can do to try to keep people safe. But I just wanted you to know that even if you're not a current grantee, there are going to be funds available. I know that there's senior centers out there and programs currently right now that serve the 60 and over population that aren't receiving grants. And we want to make sure that we are able to help out any of the programs in the state that serve seniors and not just our current grantees. So keep an eye out on the Alaska Public Notice website. All of our grants will be posted and notified in that site. So if you haven't signed up for that, please sign up for that, and then you'll be alerted when those funds become available. And that's about all I have to say right now. I look forward to working with everyone, and please always, you can look me up on the state website, but always feel free to give me a call if you have any questions about additional funds or COVID activities to keep people safe during the pandemic. Thank you.
Okay, Lisa, thank you. And she means it when she says she's open to phone calls and emails, and she will follow up. I want to remind people that if you want to put your questions down on that chat, which is a little thing up on the side or the bottom, it says chat, we will be answering questions after we go from all the different senior centers. We're going to have short reports from some selected senior centers from across the state. The first one is the Anchorage Senior Activities Center, which is from the Executive Director, Rebecca Parker. That's the center I'm most active in, and they have really done some leadership roles in terms of putting some material out. So Becky, you're up. Unmute, Becky.
Okay, good morning. All right.
And turn your camera on too, Becky.
Pardon me?
Turn your camera on too.
Oh, let's see what happened to my camera. Okay, start my video. Okay, I'm back.
Okay.
All right, thank you. I'd like to say thank you to Emily and Leslie and Gordon for organizing this, and to our speakers today. I want to mention that the Anchorage Senior Activity Center, we are an activity center. So we're a little different from some of the other senior centers. We do not have housing. We are a 35,000 square foot facility. We have everything from a restaurant to fitness center. We have classrooms, ballrooms, library, all kinds of activities. Our mission has been really focused on health, wellness, and fitness, and social interaction is our primary focus. We are also accredited by the National Council on Aging. And we are right now, we're really trying to stay focused on remaining connected to our seniors, not disconnected. So we're doing fitness and Zoom classes, nutrition education by Zoom, our memory cafe with Alzheimer's Resource of Alaska, our partner, and we're also making calls to all of our members, keeping in touch with them. We look forward to reopening. We're not sure when this will be, but we're getting prepared just because I think it's the Girl Scout in me, be prepared, and we're doing just that. Our organization, we have drafted a COVID reopening plan with the assistance from Safe Logic Alaska, a consulting firm who is risk management and safety focused. And we have a document that we have sent out to many of you to share. And, you know, if it's helpful, that's wonderful. But we have also trained our employees, our volunteers, and our board within the last 2 weeks. And we plan more trainings before we obviously reopen. But it's a good start, and I think it's a great way to start implementing new behaviors and just getting people used to all the sanitation that we have to consider in reopening. Some of the equipment and sanitation that we've purchased, and it's on hand and we're ready to go, has been handled by Stephanie Rose, and I'm going to give you her name and number because she's the contact if you need any of this equipment and haven't been able to locate it. It's srose@anchorageseniorcenter.org. Her phone number is 770-2005. She has found all our sanitation stands, sanitation materials, plexiglass for our desks and public areas, for our Medicare counselors and others who are interacting with the public. We have foggers, 3 of them, 2 handheld and a large piece of equipment. We ordered through OxyTime, and it's a light mist of hydrogen peroxide, and you can dispense it from a small handheld dispenser, or we have one, a larger one for, which is backpack styled, that you carry on your back, and it can do a room in just a matter of seconds. So those are some of the things that we're doing, and I just wanted to share that with you, and I'd be happy to answer any questions.
Thank you, Becky, for being so kind to offer those services to other places around the state. You really have done a good job in setting it up, and I encourage people to contact you either by email or phone to take advantage of it. Thank you for staying around.
Make that plan available as well, so you can contact me or Stephanie.
Our next speaker is Pat Branson. She's been the executive director of the Senior Center of Kodiak for over 32 years, a center I might add I belong to. It was the first center in Alaska to be nationally accredited to the National Council on Aging and National Institute of Senior Centers, and has been re-accredited 4 times. They provide an array of home and community-based services, including congregate meals 5 days a week, home-delivered meals 7 days a week, adult day socialization 7 days a week, respite, lifeline, chore, case management, information referral, Medicaid waiver services, and is the lead agency for the Kodiak Public Transportation System, CATS. And with CATS, which I'm hoping is more successful than the movie, you're on, Pat.
Okay, here I am, and thank you for that introduction. And so, like most providers, we have suspended services in congregate settings since March 13th. We've added a home delivered meal route, 2 routes that we now have, with the more than doubling of home delivered meals, and probably most people who should have been on the home delivered meal list now are taking advantage of that. So we've kept all of our employees on board with cross training. We've done spring cleaning and really getting to know each other from the different departments that we have. We now have plans to have a few adult day participants in a group setting at an assisted living facility, and also to use one of our vehicles because we're the lead agency for the Kodiak Area Transit System. So we have buses. We're going to have a sing-along ride with some of those participants, and also some one-to-one activities, and we'll see how that goes. We're starting that on Monday. So just doing things in phases. We're going to evaluate chore and respite next week as well. So of course, no congregate settings, no plans to open at this time. We don't have staff. We don't have money to do the kinds of things that Becky just talked about. We are doing programs on Zoom and some outside activities, since we have a wonderful patio that would accommodate the social distancing and a huge parking lot as well. We're calling seniors, we're sending cards to them, we're doing information and referral by phone and through the front door being closed. So one thing I want to bring up, and I've seen some questions about this on the chat, is that we're very concerned about cash flow, especially at the end of this fiscal year. We have not been able to bill Medicaid for any of our waiver services being suspended. And the only guidance that we've received is from the state and for the feds is for this very complicated federal application for Medicaid reimbursement. We all know the grants don't come close to paying for any kind of expenses. So we don't know when adult day services will be safe at some point to reopen. But with this happening, and these very important home and community-based services not having service right now for participants or caregivers, what happens to these participants and family caregivers when these services are continuing to be suspended? I know that participating in teleconferences in the lower 48 and national conferences is that there are many congregate settings that aren't opening until there's a vaccine, or maybe in the spring next April. So there is some funding available through PPP. Municipalities are giving out funding, and I hope you're all checking into that. But which funding programs are going to be able to carry us through this winter and to next spring and to take care of some of these home and community-based services that have been suspended? We don't know when they're going to be opening. That's a concern of mine, and I'm sure of others as well. Thank you, Gordon.
Thank you, Pat, and we appreciate the direct and frank concerns. That's part of the purpose of this, to deal with that. And I guess I may see an increase in my membership dues. Our next speaker is Marianne Mills from Catholic Community Services, and person who's succeeding Becky as the chair of AgeNet, a group that we work closely with. Marianne Mills is the program director of the Southeast Senior Services, which operates 20 different homes and community-based programs throughout Southeast Alaska, including adult day socialization, case management, family caregiver support, health promotion and transportation services, as well as congregate and home delivered meals for older Alaskans. She has worked in the area of senior services for over 30 years and has special skills in grant writing, planning, program development, and legislative advocacy. She also recently became the president of AgeNet. Again, our congratulations. And Marianne, you're up.
Thank you, Gordon. Well, at Southeast Senior Services, we operate a network of nutrition and transportation programs throughout Southeast Alaska through 11 senior centers. And I will let you know the names of those communities: Angoon, Craig, Haines, Hoona, Juneau, Cake, Klawock, Ketchikan, Saxman, Sitka, Wrangell, and Yakutat, Skagway. Most of the communities that we serve are accessible only by boat or plane, so there can be some challenges involved with that. I'm very proud that in this difficult time when we had to close our congregate programs, that our staffs really stepped up to the plate and doubled, tripled, and in some places quadrupled the number of home delivered meals to the elders. In Klawock, for example, in April of 2019, they provided 263 home delivered meals versus in April of 2020, they provided 1,089 home delivered meals. So thank you to the Klawock Senior Center for doing that. In Juneau, our meals are delivered by volunteers, and we had a wonderful corps of volunteers and staff that more than doubled the number of home delivered meals to the elders there. Each community varies in terms of the elders' sense of wanting to remain sheltered in place versus being ready to go back to congregate meals. Some of our communities ceased transportation services during this time. while others, for example, in Wrangell, they continue to provide transportation for the local elders. In some communities, Ketchikan, Juneau, what they did was they limited the number of elders, like 1 elder per bus when they transport them, or in Juneau, 2 elders per bus. Right now they're up to 3, and the elders are encouraged to wear, actually they're required to wear masks at the current time in the bus. I'm really glad that Pat mentioned the adult day programs, because our adult day programs, I'm quite concerned about, not just ours in Southeast, but also in around the state. In order to have a sustainable adult day program, it's critical to depend on private pay and Medicaid. And so I'm quite concerned, since we're not able to do those group congregate activities, how that's going to affect these adult day programs financially. I'm pleased to say that in Juneau, we have begun one-to-one programming. We have 1 client come in the morning with 2 staff members, and then we sanitize the area, and then a different client comes in the afternoon. This has provided not only therapeutic activities for the elders, but also the family members, giving them much needed respite. We have noticed a real increase in the phone calls from family caregivers to our counselor in our family caregiver support center. It's been a real stressful time having their elder with dementia home 24/7. So we look forward to being able to safely provide programming once again in our adult day programs. I think that's all I have to say. Thank you very much.
Thank you for that excellent presentation of a fairly complex program. Our next speaker is Betty Denny. She's the Executive Director of the Upper Tanana Senior Center. And you're on.
Can you hear me?
We hear you loud and clear. Please go ahead.
Good morning, everybody. When I say we, Upper Tanana area has Tok, Tanacross, Northway, Tetland, and Eagle. And we serve Glen Ellen area, and that includes Copper Center, Gulkana, Gakona, Nelchina. And we cooperate with the Copper River Native Association there for our meals. They receive Title VI, and we receive Title III, so we combine and work together. Our site closed on March 19th, and then we were closed for about a week or 2, some of the sites. And then after regrouping, we reopened with our cooks and drivers ready to prepare our meals. And there has been no direct contacts with elders or seniors. Most all has agreed to leave a box out. So that has worked real well with a majority. The Tok itself has we have delivered 40 meals a day. We deliver 40 meals a day. In Northway, we do 30 a day. In Tetland, 25. And in Glen Ellen at our contract lodge establishment, they provide at least 70 meals a day. And we also decided to give our cooks and our drivers one-time only hazardous pay due to the working in just due to being out there risking, their health and all that. So we gave them a one-time hazardous pay. And there's only one case of the virus here in Tok, and that's from a lady that winters out in Florida, who came back and had the virus, and he has not spread. So we were lucky, even though we're the first town that people hit when they come into the state of Alaska. We're very fortunate with just only having that one case, and she has recovered. The lady that has it has recovered, so we're doing well so far. And we will follow any kind of protocol that is established to reopen. So we'll just keep our ears open and go from there. Thank you, and that's all I have this morning.
Thank you. I would be shot if I didn't mention Anna Frank is the queen of the Alaska Commission on Aging, and we follow her direction. And when it comes to TOC, she makes sure you're not forgotten. The next part we will be dealing with is question and answers. Those people who have put a question in the chat will be handled first, and give Emily some slack. So Emily, you want to read the question and then we can direct it to the appropriate speaker.
So the first question in the chat that I think several people are interested in is, Lisa or maybe John, if you could address Carolyn's question about adult day centers and ability to bill Medicaid.
What is that question? I'm sorry, I don't know. So to clarify, adult day centers cannot yet bill.
I'm going to ask other people to close off their mic.
Oops.
Carolyn, can you re-ask your question?
I see a question from Kyle about, to clarify, adult day centers cannot yet bill to Medicaid for Zoom meetings programs with clients and staff. I'm going to have to refer that to our Medicaid unit. I currently don't know all the Medicaid regulations as far as providing services through telemedicine or through distance. So I don't know, John, if you're able to answer that, or if there's anyone else from our SDS Medicaid unit online who could answer that.
John, can you throw any light on this? If not, if you send an email to Lisa, I'll ask Lisa if you would follow up and respond to her and to me. I would appreciate it. Okay, what's the next question, Emily? What's the next question, Emily? Okay. While waiting for Emily to get back on, I'll have a question that will come up. John, can you give us an idea of how things are processed in terms of how the decision making is about opening up, or when to open up, or the partially open up? Just give a quick explanation of what that process is.
Yes, thank you. And you know, as we've been discussing during this call, this is a complicated and challenging virus that's really creating a lot of issues. And one of the things that the state needed to do, and I think it's made great progress, is increasing testing capacity. That's a really important aspect of being allowed to reopen up. CDC and CMS have issued certain criteria for states to look at and consider before they open up various settings, and some of it includes adequacy of testing, adequacy of supply of PPE in the state, whether or not there's active community spread, whether or not there's adequate hospital capacity, ICU capacity, ventilator capacity. There's a whole host of issues that the state needs to consider before they open up certain congregate settings. And you know, states made a lot of progress in this, and I think certainly COVID gets the vote. That's something a line I've used before, and as we've seen the last couple of weeks, there's been significant increase in COVID activity around the state, and it's not just limited to one area. So these are all things the state needs to consider, and all these issues interconnect. You have hospital issues, nursing home issues, residential settings, and then the settings that we're talking about today. These are all interrelated. The populations that use the senior centers and other forms of non-residential congregate settings oftentimes go back to assisted living facilities, et cetera. So these are all interrelated. And as the state has increased its capacity, I think we're a lot closer to being able to open up certain aspects of these settings. And at the end of the day, these are decisions that the governor and the commissioner will make, and based on the evidence of what's going on and our readiness as a state to open up. And so these are things that are discussed every day at a senior level. And we'll really, I don't want to mislead about where we're at, because this COVID is certainly shown to be a very challenging virus. So, but these are all things that are being discussed each and every day.
Okay, Emily, thank you, John. That was a good explanation of what the process is. And as there are any changes or updates, we will also make sure that everyone on this group knows that. Emily, are you back?
Hi, Gordon, can you hear me?
Yes, you're back. I'm going to turn it back over to you. You can follow up with some more questions.
Okay, sorry about that. So our next question is, for those that are 60 and older who get COVID-19, what is the hospitalization rate for that group?
This is Eric with the section of epidemiology. I can try to talk a little bit about this. So I don't have a specific proportion of people hospitalized by age. That's actually a kind of tricky thing to calculate because it would require knowing the total number of cases, which is actually hard to know because there is a lot of mild illness. I think we can be confident that older people are more likely to be hospitalized and certainly more likely to die as a result of COVID-19 than younger people who are infected. But we have had many older people in Alaska and elsewhere in the United States and around the world who have had COVID and were able to care for themselves at home just fine and recover. So I think even in some of the higher risk populations, there is a really wide spectrum of illness. In the higher risk populations, by definition, that's what makes them higher risk. More severe illness is more likely, but it doesn't happen all the time, and in fact, there's lots of mild illness in those populations as well. So I think this really gets back to the key ideas we've talked about with symptom screening, that don't somehow expect that because someone is older, or maybe has a lot of health conditions, that it'll be obvious that they have severe symptoms. It turns out that it doesn't work that way. And people of any age and any health status can have symptoms and severity that really run the gamut.
Thank you. Our next question is, what is the difference between a cloth face covering and the commercial masks that are used in facilities?
I can try to address that as well. So face masks, so surgical masks, medical procedure masks are what we consider to be PPE, or personal protective equipment. And they're different from the fabric face coverings in a number of ways. And one of the ways that they're different is that the medical or surgical type face masks have gone through a rigorous process of assessing their properties, and different ones actually have different properties around how much they protect against splashes and things like that. And so that's why we formally consider them PPE, because they meet certain standards. For the fabric face coverings that we're encouraging to be used in non-clinical settings, those, we believe that the primary benefit of those masks or face coverings is what we call source control. And this means that if the person wearing the mask is infectious but just doesn't know it because they haven't developed symptoms yet, or they're not going to develop symptoms at all, or maybe they have really mild symptoms and they don't realize that they're COVID, though of course that's something we're trying to overcome through education and screening, that this source control will keep them from spreading the virus to others as easily. Now, it is possible that non-medical fabric face coverings may provide some protection against infection as well. The evidence is really mixed on that, and we don't want to tell people, especially people who know that they are exposed to someone with COVID, so like healthcare providers working with patients, that a fabric face covering will keep them safe, because we just don't know if it will or not. And there's actually a number of ways that face coverings might help keep someone safe. I mean, people kind of intuitively think that they block out particles, and that might be part of it. But another way that face coverings might actually help prevent people from getting infected is that if you're wearing a face covering, it's kind of a reminder to not touch your nose and mouth. So that hand to face movement might be lessened if you're wearing a face covering. So that has been hypothesized as a way that fabric face coverings could also help prevent infection. But I would say that the main difference is that we focus on the use of medical, surgical, and medical procedure face masks in healthcare settings, and many of our highest risk settings like nursing homes. And then from a more community standpoint, we focus on the fabric face coverings. And I think we're all aware that there's a kind of wide and complicated mix of facilities in between, assisted living facilities and lots of other things that aren't necessarily strictly clinical, but also are higher risk than the general population and are just different from, somebody going to the grocery store. And many of our assisted living facilities have been using the surgical or medical type face masks, especially for their staff. So that definitely would be an option there as well.
And Eric,
go ahead, Joe.
Oh yeah, sorry. Go ahead, Ann.
Just a couple of different, quick little things I was going to add. Clearly, there's the face coverings, there's surgical masks, and particularly the surgical masks appear to work better at both source control and potentially a little more protection. We have additional supplies of those, and particularly given vulnerable settings like many of you work in, continue to try to get those out to you. We're also seeing movement in the supply chain. And then an N95 mask is really kind of for people who are doing aerosolizing procedures. And appreciate all the cooperation across the state on that. Also, I wanted to just let this group know that you can directly order kind of an improved cloth face covering from FEMA that is thought to be quite effective at source control. And I'll get the link and I'll post it in here and I'll share with you all, but that's free from FEMA that you guys can get then for the people that work in your community or for visitors or for staff. So I just wanted to make sure that you guys had that information. Sorry, Jeff.
Great. Thank you, Ann. Yeah, and this is Joe McLaughlin. I actually wanted to add a little bit to the previous question. The questioner was wondering about hospitalization rates in older populations and how they compare to the younger populations. There was a very nice morbidity and mortality weekly report, and that's CDC's weekly report that they put out that came out on let's see, this one actually was this week, entitled Coronavirus Disease 2019 Case Surveillance in the United States from January through the end of May. So basically they looked at the first 1,320,000 cases of reported COVID-19. And it's worth taking a look at, I think, for everybody, just to really get a sense for the epidemiology of COVID-19 here in the United States. But what they found is that overall, of those 1.3 million people who have been infected, 14% were hospitalized and 2.3% reported ICU admissions and 5.4% died. And if you look at the hospitalization percentages by age group, it's a stepwise progression. Basically, the younger age groups, you've got very low hospitalization rates in the low to mid single digits. And then once you hit into the 50 to 59 year age group, the hospitalization rate jumps up to the double digits, 13% there. 60 to 69 year age group, 22%. 70 to 79 year age group is 34%, so just over a third, and about the same for those over 80. And then the hospitalization rates do go up with, people who have reported underlying health conditions.
I think I'm going to have to cut you off here.
Yep, sure.
Emily, can we do another 10 minutes, or we have to close?
No, I think we can do another 10 minutes.
Okay, let's go to the next question, though. But I think that other material is interesting, but let's see if we can get a couple more questions in. What's the next one, Emily?
Okay, this one should be a short one. So can those that live together as housemates eat together, even though they're not necessarily the same family?
Okay, so we can talk a little about the bubble. Who would like to answer that?
I could take it.
Sure.
Yeah, so I mean, if you're living together, living close quarters, that's pretty much the same exposure risk as if you're eating together. Eric, anything else to add?
No, people who live together, for the purposes of epidemiology, I think we would consider a family.
Okay, Emily, the next one.
All right. The next question is there an app available that facilities can use as a symptom checker when they are eventually able to reopen?
Great question. There are numerous symptom checkers out there. CDC has one out. Google and Apple have put one together where you can go through the symptoms. Some people like to do it on paper. Some centers have made their own and done it. So there are lots of commercially available kind of app checkers to look at people's symptoms.
Okay. Next question, Emily.
Would having a black light to check surfaces be beneficial?
I'm handing that one to Eric and Joe.
I'm not aware of any evidence that it would be. Doesn't mean it's not, but that's not something I would prioritize investing in if that's the question.
Yep, I would agree.
All right, next question, Emily.
Okay, so the next question, the focus of this was for non-residential settings, but lots of questions about assisted living and whether or not they would be considered and follow the same mandates as skilled nursing facilities.
So happy to kind of start on that. As many people in the comment box have mentioned, and that we are all very aware, assisted living facilities have unique challenges, some very similar to long-term care facilities and nursing homes, some very different. we're really working on trying to create guidelines for the whole spectrum, from healthy congregate settings to people with significant medical concerns. I think the big things you need to be thinking about when you're thinking about your facility and what ways you can keep people safe are the number of people. So a lot of people in your center, an outbreak can mean a lot of people being sick versus a very small ALF is going to have a lot less people, even though each one of those people being sick could be very problematic. You need to be thinking about the complexity of the patients, so their ability to be able to socially distance, either because of behavioral or because of physical aspects, the ability to be able to wear a mask or to hand wash, the ability to stay distanced from visitors specifically. Also be thinking about the complex medical and behavioral nature of the people in your residencies. There is a large variety across a large distance and spread across the state. Clearly, the long-term care facilities and nursing homes are kind of the most high risk and spending a lot of time working on that, but we are working on guidance, as John mentioned, for all of them. And this is we are not alone as a state trying to struggle with this as quickly as possible. This is the #1 question that is happening across, when I'm talking to my counterparts across all of their states, is this real struggle for our need to be able to be connected for visitation and to have people be able to survive this long term, but then also mitigate the risk of COVID. So sorry, there's not been any easy answers, but we continue to push through it. I don't know if others have other things they'd like to add.
I'm going to move us along. This was advertised as a non-residential setting, and if there is interest in it of working in residential settings for older Alaskans, we certainly can do another seminar. How about 2 more questions before we wrap it up, Emily? What's next?
Sure. So the next question is, a lot of seniors are asking where they can engage in community events like ordering food or going to restaurants, but they still are unable to go into their senior centers. How do you suggest responding to them?
I think it's a great question, and it is a challenging one. You know, we see this all the time in all sorts of centers. We are kind of all trying to, I kind of think of like my kids, half the time they don't fit in their clothes. I would say half the time these protocols don't quite fit where we're at. And it's based on both the community spread as well as all the different aspects. And we've seen businesses open incredibly rapidly. I think, again, we just need to realize that the more people that we have together, the more mixing, the closer the space, the higher the risk. We are working as fast as we can to provide additional guidance on how to kind of open up safely, and just really appreciate all of the great questions and partnership as people are thinking about how to do that safely. But just because a restaurant is open doesn't necessarily mean that there is no risk for someone with underlying medical conditions to go to that restaurant and have dinner. So just because something's open doesn't mean it's necessarily safe. And I think that there is a lot of personal responsibility as well as responsibility of businesses to be thinking mindfully about the risk of COVID. We get asked a lot, will you approve our plan to make sure it's safe? There is a large spectrum between safe and risk, and there's a continuum between those things. And so trying to just get out as much information as we can about the risks associated with COVID, the tools to mitigate it, and asking businesses, individuals, families, communities to be able to find creative ways to do the things that are most meaningful to you, but then also are reducing the risk of COVID.
Okay, and the final question, Emily, before we wrap up?
So I think we've answered the bulk of the questions. I would encourage everyone to look through the chat. There were some great links added and also some email addresses added for people with specific questions related to billing for Medicaid. I think that's it.
And if you can put your PowerPoint up with the email contact web address, that would be helpful. And I would encourage everyone to get a hold of Emily or myself. You can get a hold of the state website, Senior Disability Centers. That's where John is, Department of Public Health, Alaska Commission on Aging. And give us feedback too. If this is something that's useful, we can do it again. And we hope we'll do it better each time with your input. If you have additional questions, again, that would be the source of where to send it to. And I want to thank the 250 people who are on this line from across the state. Our speakers, we have a wonderful partnership with the Senior Disability Services, our co-sponsors, HNet and Alaska Housing. I'm sorry we didn't hear about Alaska Housing this time in terms of these type of programs. And I want to thank you all for hanging in there. This is not easy. This is one of those once-in-a-lifetime events, hopefully. And thank you for all participating. And with that, I will say goodbye.
Thank you.